So, hello and welcome to another series of the e-seminars from the ERA-EDTA, European Renal Association, European Dialysis and Transplant Association. My name is Christoph Wanner and I'm chairing today this e-seminar. We have a special topic on new pharmacological therapies to slow the progression of diabetic kidney disease, and especially what is the new message, the new data, what is in the new heart failure trials for a nephrologist. We have today a prominent speaker. It's Professor Per-Henrik Groop from Finland. Actually, he is a professor of internal medicine, but also a nephrologist, chairing the Department of Nephrology for many years, but in the moment, the chair of internal medicine. And I think that's fine, overlooking the two aspects of heart failure and kidney disease. And I want also to point you out to the fact that he is the PI and created the Findiane study in 1997. And therefore, I think, Per-Henrik, I can call you also a diabetologist. We also have a good panel tonight. And with us is Beatriz Fernandez-Fernandez. She is a nephrologist from the hospital of the Fundación Jiménez Díaz in Madrid, and also a member of the Grupo Español de Estudio de la Nefropatía Diabética, as well as a member of the ERA-EDTA, the Young Nephrology Platform. So welcome, Beatriz, and let's discuss later with you. And with us is also Maria Soler. She is a nephrologist and council member of the ERA-EDTA. Both of you, Beatriz and Maria, you have written a number of papers in the area of SGLT2 inhibitors, and you can be called experts, and therefore we ask you to come today to discuss with us. Maria is a nephrologist at the Hospital Universitari, University Hospital of Vall-d'Hebron in Barcelona, and also recently elected as the new editor-in-chief of Clinical Kidney Journal of the Association. So congratulations and welcome, Maria.
Thank you.
And most important for me here with us is Niko Marx. He is a professor of medicine and cardiologist, chair of the Department of Cardiology of the University Hospital in Aachen, Germany. And Niko, you also can be called, I think, beside being a cardiologist, a hobby diabetologist, because you have written prominent papers, you are contributing to the major trials, you are an expert in heart failure, and I think I can name that you are one of the first who has created a cardiorenal ward where you join with the nephrologist and see patients together with both diseases, heart failure and kidney. And therefore, I'm really delighted that you can join the group of nephrologists to help us with some special question about the heart.
Thanks, Christoph. Pleasure to be here.
So I think this is sufficient with my introduction. The special format tonight is that we have Professor Per-Henrik Groop as introducing us with some slides where we can extensively discuss later on. And I think we always benefited from the discussions. You, the audience, you are muted, but you can listen and you are invisible, but you can enter your questions in the chat function, and we can later discuss the questions you have and we see in the chat. We have also received a number of questions already and prepared for a lively discussion. So as I'm now speaking with the words of Professor Per-Henrik Groop, because I know him well, Pera, the floor is yours.
Thank you very much, Christoph and dear colleagues, Beatriz, Maria and Niko. It's a great pleasure now to talk about what is in the new heart failure trials for a nephrologist. Very important topic. And so thank you, Christoph, for involving me in this. Before I start, a few disclosures. The first topic what I would like to highlight here is that CKD is a main driver of risk of cardiovascular disease, heart failure, and also premature mortality. If you look at this slide, this is a very important slide in the sense that if you have a 60-year-old type 2 diabetic patient, just by having diabetes, you can expect a 6 years shorter life expectancy. And if that patient has suffered myocardial infarction or a stroke, actually you can expect 12 years shorter life expectancy. And this is something that cardiologists know very well. However, we nephrologists, when we see a 60-year-old patient with type 2 diabetes with early signs of diabetic kidney disease, albuminuria, or an eGFR below 60, you can expect 16 years shorter life expectancy. And this is something that we absolutely need to be aware of. We need to find these patients and we need to take action. This slide on the left shows that when a patient will as seen in this Swedish diabetes registry, when the patient loses kidney function, the risk of ending up in hospital because of heart failure increases manifold. And the same is true for the more albumin that leaks into the urine, the more likely the patient is to face a need for hospitalization for heart failure. So CKD and heart failure, they go together. And actually, it's much, much more common than we think. So 39 to 60% of patients with a chronic heart failure will have CKD. And heart failure in itself increases the risk of developing CKD twice. So they go together, heart failure and CKD. Why? If you look at this rather busy slide, on the right-hand side, you can see when you have kidney dysfunction and you lose eGFR, that actually will cause an activation of the renin-angiotensin-aldosterone system. You will see sodium and water retention, vasoconstriction, and you will also have a sympathetic drive. And basically, water retention, activation of RAS system, that will have strong effects on the heart. That will in itself elicit humoral signaling. You will see fibrosis, you will see chronic inflammation, etc., etc. But also you will see a lot of hemodynamic effects that also will have an effect on the kidney. So what this slide actually shows us is that if you have a patient in front of you with problems in the kidneys, watch out for heart failure. If you have a patient in front of you with heart failure, watch out for problems in the kidneys. So a problem in one organ will probably be also there in the other one. So they go together. Now, let's now focus a little bit on the EMPER-reduced, which is the most recent heart failure trial, where we also have interesting data with respect to the kidneys. The EMPER-reduced was a randomized double-blind placebo-controlled trial, empagliflozin 10 milligram on top of standard care versus placebo on top of standard care. And of course, the primary endpoint, because this was a heart failure trial, is time to first event of adjudicated cardiovascular death or adjudicated hospitalization for heart failure. And a secondary endpoint, the slope of change in eGFR. And let me come back to this later on. So the primary endpoint in the EMPER-reduced was met. You can see a hazard ratio 0.75. So when the patients were exposed to an SGLT2 inhibitor, empagliflozin 10 milligram, you could reduce the risk of ending up in hospital because of heart failure or experiencing a cardiovascular death by 25%. Wonderful result. However, as nephrologists, we are interested in what happens in the kidneys. And what you can see from this slide is that in the EMPER-reduced, there was an initial drop in the eGFR. And this is what we have seen in all SGLT2 trials. Initial drop, and this has been of concern to a lot of our colleagues, but let me remind you, this is of no concern this is a hemodynamic effect, and actually the result of that these medications work. After this initial drop, you will see the stabilization of the eGFR, and after that, preservation of the kidney function. And at the end, when you actually stop the drug, you will see a rebound effect. And this was seen in the Emperor reduced as well. Now, let's have a look at what this slope means and what it tells us. So this initial drop here, that's an hemodynamic mechanism of action. And after that, you see the stabilization. And after that, what you can see, if you expose the patient to an SGLT2 inhibitor, you will slow down the eGFR loss over time. And this is exactly what we need to achieve in our patients, because when they lose kidney function, that will lead to an increased risk of dying early, cardiovascular events, and also ending up on dialysis. And then here at the end, you will see a rebound effect when you stop the SGLT2 inhibitor. Now, Christoph, Wanner, and myself, we were involved in an analysis of the first SGLT2 trial out, which was the EMPA-REG outcome trial. And by the way, if you think what this REG stands for, it's not regulation or regulatory, it's removal of excess glucose. And that is exactly what we do when we provide an SGLT2 inhibitor. We remove excess glucose. So here you can see, when you look at the slope, the first 4 weeks, empagliflozin was associated with a reduction in the eGFR. And as I said, this has also raised some concern, but it should not lead to any concern, because if you look at the long-term effect, the chronic effect, you see a preservation of the kidney function. And then at the end, you see a rebound effect. So this significant effect here in acute, and this significant effect here in the chronic phase, and this significant effect here at the end, but you can see they go in different directions. So now, if you take into account the slope with the acute, chronic, and the rebound, you will have statistical problems. So that's the reason why we should look at the chronic part. And if you do that, this is a wonderful paper that I urge you to read from Jason, 2019, showing the different trials that the effect on the slope is actually associated with the effect on the clinical endpoint. And this paper also shows us that if you see a 0.5 ml per minute change in the eGFR slope, you can expect a 0.80 hazard ratio. If the effect is 1 ml per minute, 0.65. Let's now look at what was seen in the EMPA reduced in terms of change in eGFR and the hazard ratio. So this is what we saw in the EMPA reduced. You can see that after the initial drop, the chronic phase, you saw a preservation of the kidney function. Now, keep in mind that these patients were only exposed to empagliflozin for 16 months, a rather short period of time, but we could see this change in slope. And in fact, they gained renal function, or they preserved 1.73 ml per minute of their kidney function over that time period. And if you then look at how that was translated into hard endpoints, actually the hazard ratio 0.50. And I told you just that you could expect with 1 ml change hazard ratio of 0.65. And if you have a bigger effect on the eGFR, of course, the hazard ratio is even better. If you then look at those in the Emperor reduced that had prevalent CKD compared with without CKD, you can see very, very similar effect. By the way, let me just remind you that in the Emperor reduced, half of the patients had diabetes and half of the patients had heart failure of other etiologies. But you can also see here that there were some people with CKD and some people without CKD. So in essence, what we saw in the EMPA reduced, that the composite kidney endpoint was reduced by 50% over a period of 16 months. But if you look at the eGFR slope, that was a plus 1.73 ml per minute difference. Wonderful result. Now, that was one study, but an earlier study done by HF showed also similar data. The DAPA-HF also included patients with or without diabetes, dapagliflozin 10 milligram on top of standard care versus placebo on top of standard care. The secondary endpoint was a composite worsening kidney function endpoint. The problem with the DAPA-HF was that if you look at the hierarchical statistical testing, you can see that since they couldn't be secondary outcomes, they actually couldn't look at the composite kidney endpoint, so outcome. So this is only exploratory analysis. Let me then show the overview results from the DAPA-HF. I'm not concentrating now on the heart failure. They were the same effects as in the EMPEROR-reduced. So dapagliflozin also prevents heart failure, hospitalization for heart failure. But look at this composite kidney endpoint, which is an exploratory outcome, 0.71, so 29% down. And a post-hoc analysis showed that the eGFR slope, you could gain about 1.78 ml per minute, very similar as in the EMPEROR-reduced. So very good news. And then if you do a meta-analysis of these two trials, the EMPEROR-reduced and the DAPA-HF, what you can see is that, yes, in patients with heart failure, even a short exposure time, 16 months, we can prevent a composite kidney endpoint, which is actually consists of sustained 40% reduction in eGFR and chronic dialysis or renal transplantation, or also if you had an eGFR below 15, if you start the baseline eGFR was above 30, or then below 10 if you started below 30. So a composite endpoint of kidney outcomes and a positive result. So if you take home messages here, is that first, the SGLT2 inhibitors are renoprotective. And in fact, when you prescribe an SGLT2 inhibitor, you can expect a decreased risk of new onset albuminuria, as was shown in the EMPEROR outcome trial. You can also expect to reduce the level of current albuminuria. Albuminuria is a risk factor for heart failure, what I was showing here, but also for cardiovascular events, premature mortality, ending up on dialysis, and also a decreased risk of the progression of kidney function, because we are able to preserve the kidney function by exposing the patients to an SGLT2 inhibitor. And importantly here, and this is, I think, one of the most important take-home messages of today, is that the eGFR slope and the chronic slope, so not the initial drop, the acute, or the rebound at the end, but the chronic slope is a strong surrogate endpoint for kidney outcomes. And this is, of course, very helpful when we design new studies in our field. That said, Christoph, thank you very much for your attention.
Thank you, Per. A great introduction. I think we can now open with a very general question, which we already have in the chat. The first came in. We start with the discussion around slopes and dips. And I would like to ask Niko Marx first. The adverse reaction I get from some cardiologists until they understand the slope. Nephrologists have worked with slopes since 20 years, but maybe cardiologists not. Does everybody understand, or what do we have? What is the missing link? What we have to explain to cardiologists, or is this for you totally clear?
Christoph, I think that's an excellent question, because there are a lot of concerns for the drop of eGFR. But when I explain that to cardiologists, I compare that to ACE inhibitors, for example, and drugs that affect the renin-angiotensin system, where you also see a drop in eGFR. And I explain that this is a hemodynamic effect and that there's less pressure. Cardiologists focus on pressure, So less pressure in the glomerulum and that the eGFR goes down. I think it's really important to point out that this is not something like that we know from other drugs, that patients develop acute kidney failure. And once this is understood, I think people, and in particular cardiologists, get used to these drugs.
And if the dip is pronounced, that's fine, or?
Yeah.
So
it tells you, another way is what I sometimes say is, if they dip, it works.
So Beatriz and Maria, maybe you can tell us, cardiologists told me in the past, we want to have a simple treatment. And we do not hear from nephrologists to measure creatinine all the time. What do you recommend when you see these dip and the slope? Do you go in the direction of RAS inhibitors, what we recommended in the past, 1 week later, come to the office, or are you more relaxed? What is your opinion?
Okay, I think in the regular clinical practice, we don't do that so often. It means like we don't check out like in 1 week or 2 weeks. But nowadays, it's like we are adding many things into the regular clinical practice. That means you add ACE inhibitor or ARBs, then you add SGLT2 inhibitor, and then sometimes when the heart failure is like quite important, you just add sacubitril valsartan as well, or you just add now this mineral receptor antagonism. So that means sometimes you have to check out a little bit quite often. That doesn't mean it's very important. Sometimes you just get a drop in 4 milliliters per minute, 5 milliliters per minute. It's okay. You just have to check out maybe in 1 month or something. That's what we do actually.
This is quite progressive. I recently heard from cardiologists that they add one after the next, which is not what we do in nephrology. We are much more conservative, but congratulations, you are a cardio-nephrologist. So Maria, what do you think? Do you measure creatinine, or do you say, relax, I don't want to see you in the office every week?
It depends on the GFR. Actually, if the GFR is lower than 45, I used to measure after starting SGLT2 4 weeks later, 1 month later. But I don't know if I'm doing the right thing to do. You know, Christoph, this is not right, and we don't have a good guidelines for this. Actually, if the drop of the GFR is not higher than 30%, I used to maintain the same treatment. What do you used to do, Christoph? Let me pass you the ball.
I want to get this treatment to as many patients as possible, because for me, the evidence becomes more solid and more solid. And if you, Maria, if you make it too complicated, cardiologists want to see an easy treatment, once per day treatment, not up titration, not all these things what I've heard, and maybe Niko can make a recommendation. They want to hear from us, give the treatment, take the benefit, the organ protective, and wait 2 months.
Yeah. Actually, I have to say one thing. I have only withdrawn the treatment not for GFR delay. I have withdrawn the treatment for having polyuria or infection disease, but not for GFR delay in my current clinical practice. And I used to give this drug without a lot of problems. You know, it's usual for me to start SGLT2 inhibitors nowadays.
Maybe I can jump in here as a cardiologist. I think this is, for us, it's a great treatment. It's easy, 1 dose, as you said, and we don't have to worry about blood pressure, in particular in a population susceptible to drops in blood pressure and low blood pressure at baseline, like heart failure patients. Many of the other drugs need to be up titrated and so on. And so we give that drug and can be safe that the blood pressure doesn't go down too much. And we started these days already in conjunction with other drugs that we start. So in the heart failure algorithm, we used to titrate drug by drug, but we learned that this is probably not needed. And so we started, for example, an ARNI or an ACE inhibitor together with an SGLT2 inhibitor and an MRA.
That's one question. Can I? Do you decrease
please.
diuretics?
Sorry?
When you start SGLT2 inhibitors, do you decrease diuretics?
Depends on the dose, sometimes about 10 to 20%, but usually you don't run into the problem of hypotension or execosis. So we usually keep the dose.
That's something we don't see. Like there are some data about hypertension or decreasing blood pressure, but there's something I don't usually see in the regular clinical practice. That doesn't mean a lot for me.
Me neither. I agree with you, Beatriz.
Neither do I. I agree with you. I have this feeling when we start to give these drugs to our patients, but after time, I have only the feeling that when one patient has hypotension, in that patient I have to decrease, but not in the other one. I have the same feeling than you.
So, Pera, along this line of this question, Mehmet Kambai is asking in the chat if you want to give the first time an ACE inhibitor and an SGLT2 both at the same time. Do you feel happy? Is this okay?
First of all, I would add to what the discussion where you said here. I'm not afraid of the SGLT2 inhibitor in the initial drop at all, because it's a very physiological way. All the trials that have been done, none of them actually have shown an increased risk of acute kidney injury, which is of course the danger would be. None of them. And when it comes to hypotension, even in the emperor reduced with a very low ejection fraction, no problem with hypotension. When it comes to the diuretics, I would say that the only situation where I would be a little bit cautious is if you have an elderly person, let's say something above the age of 75, on furosemide. And the reason for saying that is the furosemide acts with the same transporter in the macula densa, the sodium potassium chloride transporter with ascensis, sodium, and you have absorption of that sodium, you generate adenosine, and that is constrictive in the afferent arteriole. So you modify the glomerular filtration rate. But it's a physiological way of doing this. And also importantly, what people don't take into account is that adenosine that is constrictive in the cortex is actually vasodilated in the medulla. And this is probably adding to reducing the risk of acute kidney injury. So when it comes to SGLT2 inhibitors, do I measure creatinine? No, I don't. However, back to your question, Christoph, I'm more concerned with the RAS blocker, because they work on the other side, and there is a risk if you have, for instance, a patient with atherosclerosis in the renal artery. Then there is a risk, but that especially in diabetic patients, then I would probably take the creatinine value, but not because of the SGLT2 inhibitor.
Okay, interesting. I combine 2 or 3 questions now to one for Niko Marx. We in kidney diseases, we always discuss about low kidney function, how low can we go? We don't have the label. And what is you in heart failure? You already have the label. There's also a guideline question here down here. How is the situation with the heart failure patient in the moment with low GFR, label, and heart failure?
So the eGFR for patients with diabetes used to be higher. So you shouldn't start below 50 and stop at 45, something like that. Now, dapagliflozin is approved for the treatment of heart failure, saying that you can go to 30 and even lower, but that data don't exist. If you look at the emperor-reduced data, the eGFR inclusion criteria was down to 20. And in this study, there was a strong benefit, in particular in those with a low eGFR. So we are losing our concerns here, and I can just speak from my department here. We are using it even at very low eGFR of 30 in these patients.
Can I add to that, Christoph?
Yeah.
You know, I think people should keep in mind the reason why there was this restriction in the first place is that when the SGLT2 inhibitors came on the market, they were by definition glucose-lowering medications. And we know that the glucose-lowering effect fades away when you lose kidney function. So it was quite clear that you could not put them on the market and say that, yes, use them also in people with kidney problems. That was the reason. However, what the cardiovascular outcome trials, and now later also the dedicated renal trials and heart failure trials have shown us that they work even better at lower eGFRs without any safety concerns. So now the problem is that FDA and EMA have not yet given the go-ahead to go down to 20. Guidelines in many countries, I know that, for instance, Philippines, I think we have people following this discussion from Philippines. There is down to 30, Canada is down to 30. The guidelines go down to 30. The problem is that the label in many countries don't allow that. So anything then different from the label is off-label use. So this is something that people should be aware of. I'm not concerned at all because it's not a safety issue. It's a historical relic still there that we should get rid of.
So let's go to Spain. What guidelines are you following currently in Spain? How is the situation there? Maybe it's EMA, yeah. And what are you following, global and local? And how do you see not the barrier, but the guidelines in the future and the position of SGLT2 inhibitors? One question. Where should it first line? Where does it come into treatment? So maybe one after the next. There's plenty in this question. You can start from Spain and then broaden.
Okay, I think we already follow KDIGO guidelines, new KDIGO guidelines. I think they are great, and those go below 230 or 230 milliliters per minute. That's okay. Because it's like if you see EMA or FDA, they are different. So they say you can use empagliflozin up to 45, but you can use canagliflozin up to 30, and you can. So sometimes it's like when the patient is under one treatment, I don't withdraw the treatment and change for another one because of the EMA or because of FDA. Regulatory agencies are like quite different. So we follow, or at least I follow new KDIGO guidelines. I don't know, what do you do?
Actually, I do the same that Beatriz, and actually we are adapting to Spain. Mm-hmm. We are in a group, and Beatriz is also participating on that. We are adapting the KDIGO guidelines for Spain. I hope that we will go late, so we will be able to slow down the GFR a little bit, because we have the feeling, actually in Credence study, they go till the patients start dialysis. And in the patients with low GFR, it was good. Actually, as Dr. Per-Henrik told us, the problem is that it has also not been tested widely in this type of patients. Why not in dialysis patients? We don't know. It is not clear that it will not have beneficial effect in dialysis patients. Actually, we don't know.
I think in DAPA-CKD, they were telling when we were listening to the ASN, I think it was like that. They said it was up to the investigators if they wanted to follow with the dapagliflozin treatment. Moreover, the dialysis, when the patient started dialysis, this is not going to be a randomized clinical trial, of course, but maybe we can have some data on those kind of patients. So I think it can have a possibility after or below 20 milliliters per minute. And it was actually this meta-analysis of EMPA-HF and DAPA-HF. They went up to 20 milliliters per minute, and it was okay. There was a cardiovascular and renal benefits on those patients as well.
I can add to that. I was involved in a study where we actually went down to eGFR 15. It still works. I think that the dialysis patients, of course, because when there's no residual kidney function, then you can accept that it won't work. But I think as long as you have residual kidney function, as I said, it's a physiological way you block the sodium reabsorption, and that will modify how the glomerulus, the filtration rate, and also the renal blood flow, how they work. And of course, if you have an increased renal blood flow, you will have a hyperfiltration. You will push the sodium handling in the proximal tubule. That will deplete the energy depots, also oxygen, and that will cause damage. So it's a physiological way to ease that burden on the glomeruli. And that's the reason why I'm saying that this historical restriction is really something that we need to get rid of. On the other hand, from the legal point of view, as I said, I think people need to stick to the label in their own countries. On the other hand, there is no safety issue, and we have only benefits to actually get by the use of these the medications.
And if I'm asking Niko Marx, is it so awkward to talk about dialysis? Maria brought it up. Is there any hypothesis out there that the SGLT2 inhibitor can act on the heart by any mechanism if you forget the kidney?
Well, I think the SGLT2 inhibitor, the SGLT2 receptor is not expressed in the heart. And we think that the benefit, albeit we don't know yet exactly, is probably a combination of hemodynamic effect as well as a metabolic effect due to the glucosuria and creating a like fasting state that changes the metabolism in the heart, shifting from glucose, which is the prominent source in heart failure, to ketones, fatty acids, and branched chain amino acids. But it's, from all we know today, not a direct effect in the heart.
But it seems that there is adenosine involved that is in the heart. And also it seems that I used to do also research, basic science, and is a mechanism involved with the sodium hydrogenum proton that is also in the heart. So I'm not sure about this, and some studies pointed out that it is also expressed a little bit in the myocyte, in the cardiomyocyte. So not sure at all that there is no a direct mechanism. Also, I am studying this with empagliflozin in the mouse model. Let's see. Next year, maybe I will have also results on that.
I think Niko has to read the answer to it.
Okay.
Maria, this is a believer or non-believer story to me. So the NHE, I think, is a hypothesis that's out, but the data are still very, very small, or there's little data out. And I think overall, the best data we have saying it's hemodynamic and metabolic effect. There may be something to it, but I'm on the side of the non-believer, sorry.
Oh, sorry. I am on the side of the believer, so.
Can I ask you something about this Virtue study or Soloist, which is combining SGLT2 and SGLT1 inhibition? That means there are some SGLT1 inhibition in.
Absolutely. SGLT1 is expressed in the heart. There may be a direct effect here, but the binding capacity of both dapagliflozin and empagliflozin to SGLT1 is very, very low, so tiny, and there's no effect on this receptor. And therefore, I think for these two trials, it's unlikely that there's an SGLT1 mediated effect.
And then there's a question out there, it is better working in diabetes and heart failure or non-diabetic heart failure?
Well, maybe I can comment on that. working, it's equally potent in reducing cardiovascular events, given that the overall risk of a patient with diabetes for CV death and heart failure hospitalization is increased. The absolute risk reduction is higher, but it's working in both dependent or independent of diabetes.
And Maria, one is asking whether the SGLT2 inhibitor is working better in heart failure patients than in CKD patients. Do you have the impression from the data that it is even better working in heart failure?
No, I have the impression that they have a very good diuretic action. So in heart failure, they will work good for that. But we have also data on IgA nephropathy. That is not heart failure patient, and the data is really good from the DAPA-CKD. I don't know what's your opinion, Dr. Henrik.
Let me answer that. If you look at all data from, for instance, the cardiovascular outcome trials, where you have had secondary analysis on the secondary outcomes on the renal part, the effects on the heart, the cardiovascular event is there, heart failure is there. If you look at the renal part, it seems that the renal effects are even stronger. The reason I'm saying this, if you look at the patients in Declare TIMI and also in Canvas program, where we had patients with risk factors for cardiovascular disease, you saw the kidney effects also in these patients, but you did not see the cardiovascular outcomes. So, and then if you look at for instance, the dedicated renal trials, the Credence and the Credence and DAPA-CKD, you can see that the primary outcome was a combined heart-kidney outcome. If you get rid of the cardiovascular death, the effect, the hazard ratio is even stronger. And that is in both studies exactly the same. And I think that is exactly the same case also here in the heart failure trial. So to my mind, I think this is not a competition. The heart and the kidneys, they work together. They are, keep in mind, 25% of the cardiac output reaches the kidneys. So in fact, the kidneys have to protect themselves against too much oxygen, because in diabetes, in hypertension, in obesity, you will have increased renal blood flow, you will have hyperfiltration, and you will have a burden on the kidneys. And this is the reason why in the kidneys we have this shunt. So they protect themselves against too much oxygen at the expense of hypoxia when we have hypertension, when we have obesity, and so on. So I don't think it's unexpected that the effects on the kidneys seems to be slightly more effective. On the other hand, when you have effects on the kidneys, you release the burden on the heart, because they go together, as also Niko was saying.
So it's the cardiorenal syndrome protection.
Absolutely, absolutely.
So let's go deep into the clinic and ask a nephrologist, when you are called to a heart failure patient, and the cardiologist is telling you, we have given these patients furosemide, Lasix, 80 milligram bolus every day, and his creatinine is rising dramatically. What are you doing? What are the questions to be answered, to be solved? And maybe then we hear from Niko Marx whether this is a situation and how he's handling this. So I know that you can say hemofiltration or what there are several options. What usually raising creatinine, furosemide, 80 milligram, what should I do? It's often in my clinic. So what do you think?
Ladies first.
That's very common in the clinic. So it depends on the volume overload of the patient. That means, and it's depending of the cardiac function of the left ventricular ejection fraction. That means sometimes we can just do hemofiltration if the patient's still very, very overload and it's got a lot of volume. And sometimes the patient's sometimes it's quite difficult because the patients can be very hypotensive and needs hemofiltration, and sometimes they just need to decrease a little bit the diuretic doses. It depends on the patient. It means we have to go to the bed and check out what's happening to the patient before just telling, let's go to hemofiltration or let's go to decrease the diuretic infusion or whatever. It depends on the patient. That's for me.
Okay, good answer. So I give it to Maria. Maria, do you want to double the dose of furosemide in case of resistance? We heard that we can reduce it.
I used to, it depends also in the patient, but first, maybe they have double RAS blockade. So sometimes you have to decrease mineral or corticosteroids. At that time, the antagonists maybe they need to be decreased. And the other option that we use is to blockade at different levels the tubuli. Sometimes it's not working to go only to the proximal tubuli, and you should go to do what we name it the tubular blast or something like that to try to act at the different parts of the tubuli. So maybe go for a thiazide at that time, and sometimes it works.
I understand sequential tubular blockade.
Yes, that's.
So let's go to the cardiologist and make it even more difficult and think about hemodynamics. How can I understand whether there is arterial underfilling or venous hemocongestion?
Okay, so the easy man's way is to do an echo and look at the inferior cava vein. If this is dilated, there's hemocongestion. So coming back to your first question, and I come back to the hemodynamics, I think the critical point is to see if kidney function declines, but the patient is losing weight. Usually we continue the treatment. If they don't lose weight and kidney function is worsening, this is of more concern, I think. And we do the same. We move from bolus treatment to continuous infusion of Lasix and also to reduce ototoxicity. In addition, we use the concept of sequential nephron blockade, by example, adding a thiazide or a thiazide-like drug like metolazone, for example.
What about, Niko, thinking about an SGLT2 inhibitor? Because
absolutely,
if it is also diuretic,
yeah,
and you have the redistribution of the fluid, because if you stress the patient with the high doses of furosemide, you actually get rid of the fluid from the intravascular space,
yeah,
and not necessarily from where it should go.
Absolutely. So I think then the one concern is safety here. But there's a good study coming from Belgium, and we did an own study here treating patients in an acute decompensated setting. And this increases the diuretic effect by 500 to 700 ml per day urine production. And so you want to make sure that this is not a patient with diabetic that may run into ketoacidosis, but otherwise this is very effective because the SGLT2 inhibitors reduce more the interstitial than the intravascular volumes. So this is an emerging concept, but I think we may need some more data, but there are data and studies ongoing to assess this.
But I think, Christoph, you have published on this in the nephrotic range patients, that an SGLT2 inhibitor works rather well. And these are the guys that usually run the risk of when you try with diuretics, then creatinine starts to increase.
We have seen in a set of 100 patients in EMPA-REG outcome tremendous effects in nephrotic patients with albuminuria of 8 gram comes down to 4 gram and they mobilize edema. but they didn't have heart failure, I must say. So that's, I think, a different ballpark, but you are right. So, yeah, I'm wondering whether we can use this in acute settings, because the clinical situation is quite challenging sometimes. I wonder always if left ventricular end-diastolic pressure in the echo a good parameter for venous congestion?
Not really, not really. It tells you something, but you also need to take into account the pressure in the pulmonary arteries and right ventricular function. So left ventricular is indirect, but if you ask me for the congestion, just look at the patient and look at the inferior cava vein, and then you know where you are.
Okay. There is people now looking at the renal vein. There is people in Spain working on that and looking at the renal vein, and we are starting to do that in a project here.
Then we have more questions. In Madrid and Barcelona, do you give transplanted patients an SGLT2 inhibitor occasionally?
We do.
We also do. They are not randomized clinical trials. They are some studies, but we are doing that. And endocrinologists are easy to using that in our transplant patients.
We already checked that with our endocrinologists, not because of the, not because of the decrease in renal function, but because of several, maybe they could have more infections or more problems, serious infections, and they did not. We have quite, not a lot of patients, but we have already about 10 patients or something like that, and none of them had any infection at all, and not serious problem. It works, and there are some data about that, and it works and without serious adverse events.
What about type 1 diabetes, Pera? The situation there are data, but is this in use?
Yeah, I think this is a very important question. Let me take a few minutes here, because I have been advocating for the use of these medications in trials in patients with type 1 diabetes and kidney disease. And the reason why I'm saying that is that we don't yet, after the RAS blockers, we don't have any other means to actually prevent loss of further kidney function. So we need something, and that's a proof of concept. However, there is a caveat, and that is that anytime you give an SGLT2 inhibitor, you induce ketosis. And the reason for that is that you have actually less insulin circulating, because squeeze out less insulin compared to the plasma glucose level, and that causes lipolysis. You also have more glucagon. That's also lipolytic hormone. So you free fatty acids, and when you get free fatty acids, you generate hydroxybutyrate, which is a ketone body. And that is a physiological effect. However, the problem is if the patient is insulin deficient, that can also be lean type 2 diabetic patients can be insulin deficient, and if they're also on low carb diet, then they run the risk of euglycemic ketoacidosis. We published a paper not long ago in JSM where we showed that who are the type 1 diabetics risk of ketoacidosis is those with kidney disease. So it's a little bit ambivalent here. I think this is something that could be a wonderful way in the future to prevent further kidney loss in vulnerable patients. On the other hand, you also have to keep in mind that they run the risk of ketoacidosis. So I would say at the moment, we need more data in patients with type 1 diabetes and kidney disease. But I would love to see those kinds of studies.
So from a cardiologist's point of view, we don't treat patients with type 1 diabetes and heart failure because of the risk. And in addition, if we treat a patient with type 2 diabetes and heart failure with an SGLT2 inhibitor, we provide sick day cards telling them to stop the drug if they've diarrhea, if they've to undergo surgery. And this has been very effective. And this is something I really recommend.
Absolutely.
Do you measure pancreatic resolve in your patients before starting SGLT2 inhibitors?
No. I think the likelihood that you have a, sorry?
Sometimes when we are not very sure, we do that.
Yeah, but I think the likelihood to oversee a type 1 patient is, at least in my population, is very low.
No, I mean, in type 2.
I think what you can do, just as a it's an easy way of doing. If you have a lean type 2 diabetic patient, the likelihood that this is a metabolic syndrome associated type of diabetes with hyperinsulinemia is less likely. So if you have a lean type 2 diabetic, you need to think that there might be insulin deficiency. And if there is insulin deficiency, you need, if you start an SGLT2 inhibitor, you need to make sure that they are enough insulinized and they don't reduce the carbohydrate intake too much. That's very important. And if you have a situation where you run into a ketoacidosis, the treatment is insulinization, make sure that the patient will get insulin and get carbohydrates.
Maybe one last point to that from the heart failure trials that we discussed today, the likelihood of diabetic ketoacidosis was really, really low in these trials. I think it's not an issue of major concern.
Absolutely. No, I think it's more, you need to just know this insulin deficiency, and that is of course one. But the problem here is that we have a proof of concept in terms of renal protection. And the poor patients with type 1 diabetes really don't have anything to give them. Hopefully, the mineralocorticoid receptor antagonists might provide that. We don't know, but maybe without the risk of DKA.
You are so great, all. You answer with your responses many questions. I hope the audience is understanding when then they can bridge in between. So I want to come in the final 3 to 5 minutes to 4 questions which are dealing MRAs. They include spironolactone and low kidney function, but also the future of MRA with finerenone in our kidney patients. So maybe this can be now also everybody a final statement, how to use all these instruments in our patients. Cardiologists are used many years. Maybe they are now familiar with MRAs. So how will be the future from everybody? This polypharmacy, polypill, multi-pillar intervention we have in nephrology in the future. So maybe Niko, you can start.
Yeah, short statement from a cardiologist's point of view. Multi-pillar is the right wording here. So every drug that reduces morbidity and mortality should be used in patients with heart failure and start early and combine early. And we're expecting new heart failure guidelines in spring. And I'm pretty sure that the original concept of the step-by-step will change towards another concept where we include these drugs in MRAs. Should be included here. And the new drugs, finerenone, I think we saw great data here. And this, I think, may also become a cornerstone at a certain point in time.
Great. This is cutting edge message, I would say.
Cardiology style.
What do the nephrologists say? Maria, do you want to give a statement on your perspective, MRA, RAS, SGLT2?
I think the same, but I want just a pill, a multi-pill and just one, because if not, the patient gets confused with all of the pills. So in the future, I can see a polypill, just one, 3 mechanism, RAS blockade, finerenone or one of them, and SGLT2 inhibitors, only one pill, not to lose one of them and not to forgive to take one of them. For me, it will be the same.
That's a great answer. And I see that a woman nephrologist is speaking with a little bit different attitude than the male cardiologist. But this is typical for us when we treat our patients. So great, Maria, thank you. But we have another voice from from nephrologists from Spain?
So I think we will see. It's like a little bit different from what you think. It's like we will check that there will be a polypill, of course, but we will see the data from finerenone, because I was a little bit aware there was no important differences. There was just 4% people under SGLT2 inhibitors, but these people, that didn't change a lot. You know, there was no change. The hazard ratio was not in favor of finerenone. So we will check this out. There's of course a mechanism that is beneficial, and we cannot discuss that because it's a beneficial mechanism of finerenone. But I was a little bit aware of that data when I checked this out. DAPA-HF and DAPA-CKD, they found that MRA, the people under MRA, there was a benefit when you added dapagliflozin, and it was okay. So I think there will be a polypill, and I think it will be okay, but I would like to see a little bit more data about that.
Very good. Okay, not enough, too small a group. Great. The final word, Pera, what do you think about today's e-seminar? And
thanks for that question, Christoph. Thank you for having me on board. I would take, my answer to that question that you asked our wonderful nephrologist and Niko here is I take more the cardiology side here. And the reason why I'm saying that is that you heard me say that if you find early signs of diabetic kidney disease, you can expect a 16-year shorter life expectancy with a worse prognosis than a patient has suffered a stroke and myocardial infarction. So that's a call for action. So we need to find these patients. And we know from a lot of studies, yes, we can do a lot of good things for these patients. We can have lower hazard ratios and the relative risk is reduced. However, there is still an unmet need. So that means that we need to put everything on the table. And now we have the proof of concept that SGLT2 inhibitors are renoprotective. The mineralocorticoid receptor antagonists, they work on the collecting ducts and the distal tubule, and part of the renin-angiotensin-aldosterone system. And we have seen that they have protective effect not only on the kidneys but also on the heart. So I think in the future we will either have a multi-pill, in one pill the same, but I think we just need to act. And I must tell you that I maybe 20 years ago, I made a slide series here in Finland that I called Albuminuria is not only a test result, it's a call for action. And the action today should be that we actually use all the means we have, because otherwise we are not going to have any impact on the prognosis of our patients. And kidney patients are in not a very good position in this sense. So Niko, I would like to have more on board of these medications at once.
Okay, great. I think we had 16 questions in the chat, 17 more on my table. We, the speakers, will convene in a couple of minutes to think about how we can bring answers directly from what we have not covered to the chat and to the web. And I thank the audience. We kept all on board. Apparently, not many left, or nobody left. Actually, it was an interesting interaction, cardiologist, nephrologist, heart failure, kidney. I saw two different worlds coming together. I thank you. This was lively. I'm happy. And I conclude the e-seminar for today. Thank you.